So, thank you, Christoph. First, I have to tell you a very warm welcome to everybody here in the audience. And it's my great pleasure to give you an overview on the new I-Series. This is really a great product for our daily life. And there's one personal comment. You know, I'm a very serious professor and I came from Germany. So that means there is no humor about the next 15 minutes. Please accept this. Okay, dealing with the topic of a really traditional hospital, you see we have a bright part of more than 3,000 beds are available, more than 6,000 operations a month, and for us this is really a great pleasure to have one of the biggest ultrasound centers in Europe with more than 13 scanning rooms, and most of them are equipped with Toshiba equipment. And I'd like to give you a short introduction and an overview of our new toolbox for the new I-Series. And starting with this short introduction, I'm not quite sure if you are quite familiar with the history of the Smurfs. And on your left is a Smurfette, a beautiful Smurf. And this was created by Gargamel. It's the same story like the apple and the snake, yeah, in the paradise. And the Gargamel used this to lure all the other Smurf. And then Papa Smurf changed her into what we see today. And look at the beautiness of ultrasound. This is the reconstruction, three-dimensional, based on ultrasound. Unbelievable. Of course, also very nice in the multi-slice detector CT, but we can do image fusion, and there are some typical landmarks of the Smurf which is available for us. Then Tom Gimli Smurf, that's me, a German Smurf, that's new, changed her again in what we say today. And look at this, this is of course fantasy, but as a German Smurf I have a beard. And normally I drink beer, you see it here. But you need the right equipment, otherwise you cannot use your beer. So coming to the right equipment for this evening, starting with the toolbox for abdominal imaging. And you see this is really a big liver lesion. That's a benign one, that's an FNH. This is an axial CT scan, and if you compare this image with our ultrasound image, you see we have a higher resolution on the I-Series, a great overview on the lesion. I can demonstrate the so-called quad view. This is new available. We see the perfusion, we see the arrival time color encoded, we see the B mode, we can see an overlay technique, so that means everything is free for us. We can use our dramatic new SMI technology in terms of contrast, and I've never seen vessels like that before, and of course this is superior to every MR or CT scan. If you like, you can reconstruct the central artery of this FNH three-dimensional. Everyone is free. Of course, CT gives us a great overview. This is a coronal view of the situation, and our surgeon needs this information. This is an endoscopic view where you can see the resection border is 5 centimeters. This is an ultrasound view, quite similar to CT. You can reconstruct every scan plane, you can measure your resection border. And once again, we can select every scan plane which is available for us. You can see the centralized artery very clearly, and of course this gives us the opportunity to talk with our surgeons day by day. And I can tell you, this lesion is in a range of 8 kilopascal, slightly stiffer than the normal liver tissue and very heterogeneous, which is typically for this FNH. Dealing with the topic of staging CT on your left, you see there was a small finding which occupies a simple cyst, but the big lesion behind was missed by the staging CT. And if you compare this finding with the contrast inflow, you see this arterialized inflow early enhancement, typically for a big HCC in a range of 5 centimeters, which was missed in a normal staging protocol. Dealing with another hot topic, vascular imaging. I believe the I-Series is perfect to do vascular imaging. And this is a rare case of May-Turner syndrome. And please have a look first on the schema. That's why we have a compression of the left common iliac vein, mostly in pregnant women, by the right common iliac artery. Then we do an angiography and a stent graft as a treatment. And 2 weeks later, we have a recurrence of the thrombosis. What was the reason? Look at the beautiness of SMI. You see the artery is beating the stent graft against the lumbar spine. And that's the problem here in that case. And if you like, you can reconstruct this in 3 dimensions. Another case here of the same syndrome where we can see beautiful in a 3D reconstruction all the surrounding vessels in this situation of a clear thrombosis. Another interesting case, celiac trunk compression syndrome or Dunbar syndrome. Often we see a weight loss in younger women, and mostly we have to do a surgical treatment. And there is an abnormal appearance of the celiac trunk in these cases. These are really beautiful images done by MR, of course, and you see there's a typically hook-shaped contour. I'm not sure if you are familiar with this topic. That is Captain Hook, and he's beating or fighting against Peter Pan. That's my hook stick, more realistic. This is how it looks like. And this is a Da Vinci robot image where you can see the hook stick really nicely. What can we explain with our new eye series? You see an inhalation normal appearance of the celiac trunk, and if you reconstruct the same situation in exhalation, you see turbulent flow and you see beautiful this hook stick. If you like, with and without contrast with SMI, once again in 3 dimension, before and after therapy. These images are named confusion imaging. Why? First, we start with the situation before. We see some turbulent flow in the image fusion mode, color-coded duplex ultrasound, and then the same situation after the surgical treatment. Or if you like, you can deal with contrast, see the normal appearance of the celiac trunk, and interesting for me to see also the inflammatory rejection of the surgery. And if you are really an expert, you will see the free fluid in a range of 2 milliliter. This is an election now for you. Please vote. Which image is nicer? The left one or the right one? Please hands up for the left. Hands up for the right. Come on. Okay, that's for all the Americans in the room. Please make your right decision. And if you look carefully, you will see this is a sensor-based 3D ultrasound image, which has a nicer resolution than the MIP reconstruction done by MR. And this is how it looks like. This is only a simple sweep scan 3 minutes after the contrast administration, where we can create such nice images. Dealing with a small topic, thyroid nodules. This is an interesting classification. So I will demonstrate that there is no vascular architecture included in this category. And if you have a suspicious lesion in the range of 4 up to 5 thyroids classified, then we have to separate 5 different categories. I'd like to explain how it works. First of all, we see a clear solid component in this nodule. We see a hypervascularity. Then we see this lesion is much harder than the surrounding tissue. Interesting for us, we can measure the whole area automatically done by shear wave elastography. And if you select a region of interest, you see the stiffness is doubled as high as the mean value of the whole area. Also very interesting. We can use a 3D evaluation of the lesion to see this as a hypoechoic nodule. We see microlobulations and microcalcifications. But once again, no vascular architecture is included here. I show you the microcalcification once again, and this lesion was staged thyroids 4C. An example of a typical benign thyroids 2 classified nodule, where we see there are often peripheral localized vessels, and we see this lesion is really soft. Dealing with the topic of uroradiology and starting with small testicular lesion. It's very important to understand that 10% of these lesions are typically benign, and especially if you use contrast application, we see a finding quite similar to an FNH. This is a nodule in a testicle of 5 millimeter, very well described. This is another interesting case where we see in a hypoechoic spot. In 3 dimension, we see this is not a round-shaped mass. And if we use shear wave elastography, we see there is no difference between the testicular tissue and the lesion itself. This is a diffuse bleeding after football trauma. Very interesting. Ladies and gentlemen, let me introduce Mr. Watanabe. He is one of the pioneers in ultrasound. Why? You see clearly he's sitting on his own ultrasound chair and he's scanning his own prostate. Congratulations, that's experience. On your right, 2016 image quality to pick up a tiny lesion with MR ultrasound fusion and especially targeting biopsy in terms of the fusion mode. Why this is so important? You see this funny guy with Gleason-free histology grade of prostate cancer. He's always smiling. This is not a danger. And on your right, this is the killer. He kills you definitely. And this one in the middle, this is the blue curve in the middle. You see there is a tumor recurrence if we deal with this topic, which is very, very important. One comment, you see the great B-mode quality in terms of ultrasound in contrast to our MRI feature on your left. On your right is the ultrasound image, corresponding image. We can do a lot of things. You can see we can do a target biopsy, and this is based on contrast as well as on shear wave elastography. And I'd like to explain on a clinical example. We see clearly there are two lesions identified by MR, this one, and you see this one is much stiffer, and this corresponds nicely with the shear wave elastography. So I can tell you there is a clear stiff area of 117 kilopascal in that case. And of course you have to pick up very carefully this area. Dealing with the focal therapy, so-called IRE for prostate cancer, this is also a new hot topic. This is a direct overview here in the operation theater. 10 minutes after the procedure, we can tell here is a clear perfusion defect, so the lesion is gone, and a good opportunity for the patient to use this new technology. If you like, I can reconstruct the perfusion defect three-dimensional also in the operation theater. This is how it looks like in real time. That's me sitting on your left. Very relaxed, of course. This is the ultrasound guy. You see this is our therapeutic option, and this is an endorectal transducer. We use the fusion mode. You see the box here is included to have a clear overview on the position sensor, and then we check this really carefully based on the fusion mode. This is how it looks like on your right, the application of one thin needle. And then we have a second scan plane available, a sagittal scan plane, to be sure that we have the right distance of the needle. We can visualize the whole needle tip, which is very important for our daily base. After the procedure, we can check the softening of the tumor based on strain elastography, once again in the fusion mode. And on your right, we can see the perfusion defect, and once again this beautiful SMI 3D reconstruction here of this big perfusion defect. What are the trends of the I-series? In my opinion, clearly image fusion, which is optimized. We have sensor-based 3D and contrast-enhanced SMI. This is an example where we can use everything together. An Endoleak type 3, CT-based scanning, then we do contrast application. We see, yes, clearly here is an endoleak in that case, and we have the diagnosis finally after 22 seconds. And then interesting for me, we switch back into SMI, and now you see a clearer detail resolution done by MRI. And in overlay with the SMI tool, you see we can rotate the probe and fix the problem here very carefully on the right side. So this is a great step into forward, in my opinion, on this topic. A kidney graft recipient, beautiful reconstruction here of the smallest components of the kidney graft. This big tumor is very nice visible on your right. This is interesting because this was isochoic on the B-mode scan before, and now we can outline this as an overlay, and the MIP reconstruction is done also on the ultrasound platform itself. So that means we can do a lot of things for vascular imaging, like in all these examples: renal artery, mesenteric artery, liver veins, portal vein, and this shunt graft. New informations are available on this new I-series. So let me conclude, ladies and gentlemen. Sensor 3D, for me, it's really important for vascular imaging. We have a great morphological overview, quite good comparable to CT scanning, and we have a representation free of artifacts with this technology, sensor-based. Image fusion, especially for endoleak follow-up, our last case, very interesting. We deal with this topic for staging CT day by day for focal lesions, and monitoring of the focal therapy with IRE for prostate cancer. And SMI, it's a great step to see the microvascular architecture. In my opinion, we can now integrate this into the TIRADS classification to see really these abnormal vessels. Thank you so much for your kind attention and a short comment to humor. Thank you.